In this episode, we'll look at the most important cardiac-related questions, so let's start with the first one. A 59-year-old male patient presents to the emergency department with crushing substernal chest pain, meaning he's feeling chest pain below the sternum. For 30 minutes, radiating to the left arm, and the patient appears anxious and diaphoretic, which means he's sweating profusely. Vital signs 148/92, which is a slightly elevated blood pressure. Heart rate 104 per minute, also a bit high. Respiratory rate 22. The patient has a bit of tachypnea here as well. SpO2 96% on room air. This is normal. SpO2 96% on room air means his saturation is normal. Which action should the nurse perform first? This means for an MI patient, what will the nurse do first? It's a priority question. So look here. Put your answer in the comments so I can see how prepared you are, and you can see how you'd solve this and what the answer will be. So for all the questions, put your answers in the comments. Pause the video, read the question first, then the options. After that, write your answer in the comments. So first here is, administer oxygen at 2 liters per minute. We give 2 liters per minute of oxygen. Most students choose this option and fall right into the trap, getting the question wrong because they see the patient has an MI, meaning myocardial infarction. So they give oxygen. Usually in a myocardial infarction, there's a blockage in the coronary artery. Due to the blockage, oxygen doesn't reach the heart's myocardium, so the myocardial cells get damaged. That's what an MI is. So students think that since cells are being damaged due to lack of oxygen, we must give him oxygen. However, we first need to see if the patient's saturation is normal. If it is, we won't give oxygen. We'll move to the next priority. But if saturation isn't normal, meaning the patient has hypoxia or saturation is below 90, then we'll give that patient oxygen. Normally, you should remember one principle. Whenever there's hypoxia or a lack of oxygen in our body, nitric oxide is secreted. And nitric oxide is a vasodilator that dilates blood vessels. If the patient had hypoxia here, then in our coronary artery, nitric oxide would be produced and reach there, dilating it slightly. Now, if we give the patient oxygen, that oxygen will reach the myocardium. But if the patient's saturation is fine, it means whenever oxygen is sufficient in the body, nitric oxide production decreases. It decreases, meaning less vasodilator, which means the coronary artery will constrict. So if saturation is normal, at that time, if you keep giving the patient oxygen, less nitric oxide will be produced, which means fewer vasodilators. The patient's coronary artery is partially blocked. It's also possible that the patient's coronary artery is completely blocked. If both are present, then the choice of treatment for both will be different. For example, if it's partially blocked, then it's possible to treat it with medication. If it's completely blocked, it means our treatment plan, the doctor's treatment plan, will change. In that case, he performs a PCI, a percutaneous coronary intervention, which can include an angioplasty. So we have to see whether the coronary artery is completely blocked or partially blocked. So what happens is that when we do an ECG, you must have seen 2 terms in the ECG, STEMI, meaning STEMI, which involves an ST segment elevation MI. What happens in this is that if the coronary artery is completely blocked, this is the coronary artery, and if it's completely blocked, it means oxygen doesn't reach the myocardial cells from here. When it doesn't reach them, our ST segment, if it's completely blocked, the ST segment will be elevated. This is the P, and after that, this. The QRS complex, and after that, this ST segment will be elevated, and then comes the T. So here, this ST segment, this area remains elevated. If it's elevated, it means the coronary artery is completely blocked. Now, we don't manage it with medication. Now it means we should immediately inform the doctor, and then the doctor will perform some percutaneous intervention, a coronary intervention, which means the clot will be removed by him. If it's an N-STEMI is a non-ST elevation MI. This means that if the ST segment in this is not elevated, it's depressed, meaning it's on the lower side. This only happens when the coronary artery is partially blocked, not completely blocked, but partially blocked. Here, the cells further ahead are getting a little bit of oxygen, so the treatment choice changes here. To decide all this, we need an EKG, so that means our correct answer here will to obtain an ECG. If the patient had hypoxia here, or if the saturation was less than 90, then our answer here would be different. The next option is to draw blood for cardiac enzymes. What are cardiac enzymes? The cells of our myocardium, the membrane around them, will start getting damaged due to a lack of oxygen. As soon as it's damaged, some enzymes inside this cell, like troponin and myoglobin and CKMB, these enzymes increase. If there's ischemia or myocardial infarction, all of these will increase. But by the time this test result comes back, it'll be too late because we have to see what needs to be done immediately. So while we will do this, it won't be our priority. Therefore, we'll eliminate this one as well. Administer the ID morphine. We also administer IV morphine later. First, we need to see if we should shift to medical management or if we need to perform some percutaneous coronary intervention. So this means we also give this to the patient later, because if we give morphine to the patient, it'll reduce preload, reduce anxiety, and reduce pain, which is beneficial, but it won't be the priority here right now. A patient is diagnosed with ST elevation. ST elevation means their coronary artery is completely blocked. Myocardial Infarction, STEMI. So here you have to remember that this is a condition where there's a blockage throughout the coronary artery, meaning oxygen isn't reaching the myocardium. Which intervention is the highest priority? This means all of our options here, all actions could be correct, but which one is the highest priority? Start the beta blocker. This is a medical management. In beta blockers, what do beta blockers do? They reduce the heart rate. This means they'll reduce the workload on the heart, which is what we want. That is, in an MI condition, there's a mismatch between oxygen demand and supply, meaning demand is increased and supply is low. So the faster the heart contracts, the more oxygen it needs. That is, more supply will have to be provided even though it's not there. So we give beta blockers to the patient so that their heart rate decreases, workload decreases, and oxygen demand decreases. But what's asked here? You need to look at two things here. Mostly, there's ST elevation, which means there's a complete blockage in their coronary artery. From here, the treatment plan will change, and from here, our answer will also change. Be sure to write your answer in the comment box so I can see how you're solving this question. So there's ST elevation, which means there's a complete blockage in this. What will be your highest priority? So we won't give beta blockers because beta blockers aren't going to work for this. Administer statin. What happens with statins like atorvastatin? These are lipid-lowering drugs, drugs that reduce lipids. They are lipid-lowering drugs, but they work in the long term. Immediately at that time, emergency management won't happen with this. Prepare for the PCI. PCI means percutaneous coronary intervention, in which we perform angioplasty. So we'll do this one, and by doing this, what will happen is that we'll insert a balloon through a guide wire into the coronary artery. After that, we might break that clot, or we might put a stent in there and keep that coronary artery dilated. So this will be our management here. So this will be the answer here. Monitor for the urine output. As mentioned in the last option, we'll monitor him for urine output, but in this emergency condition, there's no need to monitor for urine output. A 62-year-old patient presents with acute chest pain and is prescribed a sublingual nitroglycerin. The nurse reviews the vital signs. That is, nitroglycerin is being given to the patient. Due to MI, the vital signs show a BP of 88/56 millimeters of mercury, which is low. This means the patient has hypotension. The heart rate is 110 per minute, meaning the patient has tachycardia. The respiratory rate is 20, which is on the higher side. SpO2 is 95%, which is within the normal range. The patient appears anxious and diaphoretic, meaning they are sweating heavily and are anxious. Which action should the nurse perform first? This is also a priority-based question. It means there's an MI patient who is being given nitroglycerin. Nitroglycerin needs to be started. So, what will the nurse do first? Looking at these vital signs, if the patient is being given nitroglycerin and their BP is 88/56, then it means... Now this is a red flag here. This is what we need to look at. Let's look at the options. Administer nitroglycerin. Mostly, what does nitroglycerin do? It's a vasodilator that dilates blood vessels everywhere in the body, whether in the head, the brain, the coronary arteries of the heart, or anywhere else in the body. It dilates them, which means it lowers the blood pressure. In the heart, our purpose for this is to dilate the coronary arteries. If they are dilated, blood flow will increase, and oxygen will reach the myocardial tissues and cells. But if the BP is already low, if the blood pressure is already low, and we then give nitroglycerin, the blood pressure will drop even further. If the blood pressure drops even more, blood won't even reach the heart, because if vasodilation occurs throughout the body, then the blood won't reach the heart. What will happen is that it will stay in the other blood vessels throughout the body. And now that it's not reaching the heart, less blood will be pumped out of the heart, meaning the stroke volume will decrease. If the stroke volume decreases, the cardiac output will decrease. If the cardiac output decreases, less blood will go into the aorta and less blood will go into the coronary arteries. This means that although the coronary artery will dilate, we don't have enough blood available. So what will flow? It means the blood won't reach the damaged myocardial cells. So if even more, or you can look at it this way, if the BP is 88/56 and you still give the patient nitroglycerin, then because of the nitroglycerin, all the blood vessels in the body will dilate. If they dilate, it means the blood pressure will drop even further, potentially causing the patient to go into shock and develop severe hypotension. So this is a very dangerous condition. The option is to administer nitroglycerin? No, absolutely not. We will not administer it because a BP of 88/56 indicates severe hypotension. If we give the patient more nitroglycerin, then what will happen? The BP will drop even further. The patient will have severe hypotension and they could go into shock. So we will rule out this option here. Increase the IV fluids. IV fluids, we might increase. Some students might choose this, thinking that since the BP is low, we should give the patient IV fluids to raise the BP, because we have to give nitroglycerin to dilate the coronary arteries. Some students might think of it this way, but we should not choose this option, because if you increase fluids, if you give the patient fluids when their blood pressure is low, yes, if you give fluids, the intravascular fluid will increase, that volume will rise, which will raise the blood pressure. It will raise the blood pressure a bit, but if we continue giving nitroglycerin, it will cause vasodilation again. So the fluids we give won't be as effective because we're giving nitroglycerin at the same time, which causes more vasodilation. This means it won't be very effective here because if the blood pressure is low, we need to remove the causative factors that are lowering it further. Now, on one hand, the blood pressure is low and we're giving nitroglycerin, and on the other hand, we're giving fluids. Giving fluids will raise the blood pressure, but nitroglycerin will cause vasodilation again, which will lower the blood pressure once more. Next, hold the nitroglycerin and notify the provider. Yes, we must withhold the nitroglycerin and inform the doctor so they can find an alternative treatment. So the correct answer here would be this. Rechecking the blood pressure, rechecking just means you're delaying the next step. A 62-year-old, 3 days post-myocardial infarction, suddenly develops hypotension, jugular venous distension. This means the patient has hypotension, their jugular vein is distended, and there are muffled heart sounds. This means there are 3 symptoms occurring together here. First, the patient's blood pressure is low. Second, the jugular vein is distended. And besides that, the third one is muffled heart sounds. Muffled heart sounds. And these 3 things, whenever they occur together, we call them Beck's triad. We call these 3 Beck's triad. Triad means 3. 3 is called a triad, and Beck is the name of the scientist who described it. So it's called Beck's triad. So this patient, an MI patient, has Beck's triad right now. The patient is restless, has tachycardia, and has cool, clammy skin. It's cool, clammy skin because the patient has hypotension, which causes cool, clammy skin. Which intervention should the nurse perform immediately? This means this is also a priority-based question. What will the nurse do first? If you get this question right, I can assume your exam preparation is at a very good level. If you get this question wrong, it means you aren't well prepared. So please post your answer in the comment box so you can see how prepared you are. It's mostly confusing, a very tricky question, and this question is often asked in exams. So administer supplemental oxygen via nasal cannula. Now what will happen here is that the patient has hypotension and the patient has an MI, so in this case what does the student think? That the patient has an MI, which means there's a lack of oxygen, and the patient has hypotension. Since there's hypotension, what should we do now? So if it's a myocardial infarction, we've learned that we need to provide oxygen, so as soon as they see oxygen as an option, they immediately select it as the correct answer. But in this case, that's not what you should do. So we won't give oxygen via nasal cannula here. Next, look at the second option, an IV isotonic fluid bolus. Now, many students might think that if there's hypotension, we should give fluids to resolve the low blood pressure issue. But if you give more fluids during hypotension when the jugular vein is already distended, you should realize that more fluid won't fix the problem. We'll see why that is in a moment. Now, let's see what's actually happening here. First, let's look at these symptoms here point to cardiac tamponade. A state of cardiac tamponade is developed in this patient because whenever you see this triad, low BP, jugular vein distension, and muffled heart sounds mean they're dull or distant. It's like if we were listening with a stethoscope right here. The heart sound that should be clear isn't clear at all. It sounds as if it's coming from very far away. Why does that happen? It's because the covering around the heart, called the pericardium or the pericardial space, fills up with blood or fluid. This creates a barrier between where the sound is generated in the heart and where we're listening from. Because of this barrier, it sounds like the heartbeats are coming from a great distance. That's what we mean by muffled. The sound is dull and lacks clarity or sharpness. Now, what happens is that the patient's ventricular wall starts to deteriorate due to the MI, the myocardial infarction. If the cells here are damaged, say these cells right here, due to a lack of oxygen, then after a while, the wall can actually rupture, allowing blood to leak into the pericardial space. So there's a sac around the heart called the pericardial cavity or space. It has two layers, the visceral pericardium and the parietal pericardium. The space between these two layers surrounds the heart, and that's where the blood starts to collect. Now, once the blood is in there, you have to realize that it starts putting pressure on the heart, effectively compressing it. As more and more blood accumulates, the pressure from all sides increases, further compressing the heart. When the heart is compressed like this, it's similar to taking an inflated balloon and squeezing it from all sides. That's exactly the kind of situation we're dealing with. Now, if this compresses, the blood that was here inside the heart in the ventricle, instead of going through the aorta to the whole body, because ventricular contraction just can't happen here. It contracted well, but after that, it doesn't let it expand to fill up again like this. Because if blood fills this pericardium, the pericardial space, from all sides, it grips the heart from every direction, holding it extremely tight. Now, the ventricle doesn't fill up completely anymore, and if it doesn't fill, the blood won't be pumped out. So this blood that was here, the blood that's arrived, it will start to flow backward from here. So instead of going into the aorta, the blood coming from above won't exit. It'll flow back into the lungs, causing pulmonary congestion for the patient. Similarly, in the right ventricle, instead of blood entering pulmonary circulation, it starts pooling right here. Because the blood coming from above, well, blood only leaves the ventricle when it's completely full. If it fills and then contracts, the blood is ejected into systemic circulation. But if the ventricles can't fully dilate, and they can't because blood has pooled in the pericardium, gripping it tightly, then they won't dilate or fill properly. If they don't fill, blood just pools here in this chamber and here in this chamber. Now it starts backing up. It'll flow into pulmonary circulation from one side, and from our right atrium, it'll start backing up as well. As it moves upward, it'll flow into the jugular vein. Now blood is coming from above, but instead of moving forward, it pools right here, meaning the jugular vein will become distended. On the other side, blood coming from the body won't move forward either, because there's already blood stuck here. So now this will also start backing up right here. Now, let's see why the patient developed hypotension. If cardiac output, well, the higher the cardiac output, the higher the BP. The lower the cardiac output, the lower the BP will be. And what is cardiac output? It's stroke volume times heart rate. That's our cardiac output. Now, cardiac output is the amount of blood pumped out in 1 minute. If the heart can't beat properly, it won't pump blood effectively. If blood isn't ejected from this ventricle, if blood isn't pumped into the aorta, it's because the ventricle didn't seal properly. And if it didn't seal, the amount of blood ejected will be very low. This means that inside the body, right here, it's happening throughout the entire body. Hypotension. So this was the reason for it happening. Hypotension. So why did hypotension occur? Because the ventricles couldn't fill properly, as they couldn't dilate, because blood has collected in the pericardium surrounding them. So because they couldn't fill properly, when the heart contracts, the amount of blood ejected into the aorta will be less. Since it filled less, less blood will go out. Less blood means cardiac output will be low, which means blood pressure will drop. The patient has hypotension. This blood here, if it's not moving forward, it means it's pooling in the atrium and backing up into the jugular vein. There's backward movement, so it dilates here. Blood is also coming from above, and it's not moving forward from here, meaning the jugular vein is also distended. So those are two symptoms. The third symptom was muffled heart sounds. I already told you that muffled heart sounds mean blood or fluid has collected in the pericardium. Because of that, whereas before the heart sounds were coming through directly, now there's blood in the way, acting as a barrier. This makes it sound like it's coming from far away. It's distant, so we call this muffled heart sounds. If all three are present, you must understand that the patient has cardiac tamponade. We call this condition cardiac tamponade, which is this situation here in the pericardial space. The accumulation of fluid inside it is called cardiac tamponade. So if you see these three symptoms, distended jugular veins, hypotension, and muffled heart sounds, then you know the patient has cardiac tamponade. Now, from here, your treatment will be different and your answer will change. What would your answer be? Please write it in the comments. So, administer supplemental oxygen via nasal cannula. Now, you might be thinking this, and students often choose this option. Whenever we talk to students about what they did for this question and why they chose this option, they say they saw it was a myocardial infarction, which means a lack of oxygen, so they gave oxygen first. They say that's what they learned. Whenever there's an infarction, a myocardial infarction, you have to give oxygen. But oxygen isn't a priority here, because if there's cardiac tamponade, the pressure prevents blood from moving forward. Cardiac output will be low no matter how much oxygen you give. If cardiac output is low, then less blood will reach the coronary arteries. Less blood means less oxygen will get there, regardless of how much oxygen you provide, so we can eliminate this option. Second, initiate IV isotonic fluids. This is the most common choice. Students select this option the most. Why is that? Because they think that since the patient has hypotension, giving fluids will resolve the hypotension problem, and this is exactly where the question traps you. In this scenario, now look at this. Suppose you give the patient fluids. The fluids you give will come from here, right? From the inferior vena cava. If you give the patient a lot of fluid, it will travel through the inferior vena cava into the atrium. If the fluid enters the right atrium, it still can't get into the ventricle. Even if it reaches the right atrium, it won't go into the ventricle. Why? Because the entire thing isn't dilating. They won't be able to dilate properly, meaning they aren't filling up. So all this fluid is causing congestion here. You keep giving fluid, but it's just congesting right here. Now, if this were to come out, the hypotension problem would be resolved, but the heart is being tightly gripped by this cardiac tamponade condition, meaning this fluid. So no matter how much fluid you give, if the ventricle doesn't dilate properly in the first place, then it won't fill properly. If it doesn't fill, it won't be able to produce much cardiac output through contraction, so it will only dilate a little bit. If it only dilates a little, it means there's only a little blood in it. If there's only a little blood, it means there will be very little cardiac output. So no matter how much fluid you give from the outside, that cardiac output will remain low. If the cardiac output is low, the rest of the body will remain in a state of hypotension. This means that giving fluid here won't lead to any improvement in this condition. Next is obtaining a 12-lead electrocardiogram, meaning performing an ECG. Now, there's no need for an ECG here because by the time you do it, we've already identified that the patient has Beck's triad. Beck's triad means jugular vein distension, hypotension, and muffled heart sounds, and the patient has all the symptoms of an MI. So we immediately suspect cardiac tamponade. This is an emergency where you must immediately relieve that tension, that pressure, so that cardiac output increases and all the problems are resolved. So we won't do this here either. Prepare for emergency pericardiocentesis. Yeah, in pericardiocentesis, what happens is we aspirate this fluid from right here. We aspirate the fluid, and as a result, once you've aspirated the fluid from here, look, there's no blood left in this pericardial space. And if there's no blood or fluid here, then this pericardial membrane or pericardium won't keep the heart gripped. It will relax, meaning it will be relaxed. Now, the heart's ventricles can expand properly, undergo diastole, and fill up. So our problem, now that they expand properly, it means cardiac output will increase, which means more blood will flow into the coronary arteries. More blood in the coronary arteries means that blood will also reach the heart's myocardium effectively. So what was your answer to this? Please let me know in the comments. And we've also launched our course on the website where you can see that you'll get all these features in that course. My classes have already started there, so you can join. It will include all the classes and questions as well. The link for it is provided in the description box, or you can visit our website and enroll in our course there. Because we've started many classes in our online course on the website, a patient with an MI is ordered aspirin, morphine, oxygen, and nitroglycerin, which should be given first. Meaning, what will you give first? Out of all these, what's the first thing you'll give? Morphine? Morphine isn't given first. It's given later. It reduces anxiety and decreases preload, but it's not given at the start. But you need to see here, has oxygen been mentioned? Was the patient's saturation level mentioned? No, it wasn't. So that means you can rule out oxygen as well. Nitroglycerin, some students might think, yes, if the patient has an MI, let's give them nitroglycerin because they think it'll cause vasodilation and increase the oxygen supply. But now consider this. Suppose there's a clot here, or rather a plaque has formed, meaning a fatty plaque has built up. And if you've administered nitroglycerin, then these blood vessels will dilate. Once they dilate, it means more blood is being pumped through, which means more oxygen is being delivered. To the myocardial cells, that's fine. But suppose that in the meantime, this plaque ruptures. If that plaque ruptures, what happens inside our body whenever there's damage anywhere? When that happens, platelets start arriving there quickly, like, hey, there's damage here, let's go. So they'll come here. If they do, look, it's completely blocked because now a blood clot will form. Platelets arrived, now a clot has formed. See, it's entirely blocked now. This means that suddenly blood might not flow past this point at all. This means oxygen will be completely cut off and all the heart cells further down will be damaged. So between nitroglycerin and aspirin, you must always choose aspirin. Because if we've given aspirin, if the patient has been given aspirin, suppose you've given the patient aspirin, you gave aspirin first, and this plaque was already there like this. If this plaque is already there, meaning this much fat has accumulated, even if this fat breaks, if it breaks here, since we've already given aspirin, the platelets won't gather here and form a blood clot. They won't form a clot, meaning this path will stay open, so oxygen will reach further down properly. If you didn't give aspirin and only gave nitroglycerin, blood will flow. But if by chance this breaks, then platelets will quickly arrive here because the body will think there's damage somewhere. And when platelets arrive, a clot will form, and the entire coronary artery will be blocked. So first, we need to prevent the clot from growing, meaning this obstruction here, this plaque that's formed, or the clot here, we have to prevent it from getting bigger, and only aspirin can do that, not nitroglycerin. So our answer here won't be nitroglycerin. Aspirin will be our answer here. Nitroglycerin won't be the priority. A client who is 24 hours post-myocardial infarction suddenly becomes unresponsive. The cardiac monitor shows ventricular tachycardia, meaning they have VT, and no pulse is palpated. What is the priority nursing action? This means they have pulseless VT, and when there's pulseless VT, that is pulseless ventricular tachycardia, it falls under a shockable rhythm. This means we can treat that condition by giving a shock with a defibrillator. It's pulseless VT, right? Meaning if there's no pulse and there's ventricular tachycardia, we call it pulseless VT. And what happens in this is that our SA node isn't sending the electrical signals properly. So now the condition for defibrillation, if we give it a high voltage shock with a defibrillator, the SA node will start sending its electrical signals properly again. So we call this condition pulseless VT and a shockable rhythm. What is the priority nursing action? Meaning, what will the nurse do first? Administer amiodarone? What does amiodarone do? It treats dysrhythmia. But medical management in this condition, meaning whenever there's pulseless ventricular tachycardia, pulseless VT, or what we call a shockable rhythm, we give a shock first, and after that we can shift to this amiodarone. So that means we'll eliminate this. Initiate CPR. We perform CPR when the patient is in complete asystole. But here we have what? Pulseless ventricular tachycardia. This means first we will give him a shock with a defibrillator. So the correct answer here will be C. And after that, we will give CPR. And after that, we can provide medical management or medicine. So we won't give CPR here either, and checking the blood pressure won't do anything. A nurse is caring for a client who's 24 hours post-myocardial infarction. Which symptom requires immediate reporting to the healthcare provider? Meaning, which symptom is the most serious here related to MI? Mild fatigue, this is expected because if there's an MI, it means cardiac output must have decreased. Decreased means the body's cells received less energy, so fatigue can occur. So here, what this is that we don't need to report this to the healthcare provider immediately. This means we need to look for the most serious symptom. Headache? Look at headache. See here, the patient has an MI, and if there's an MI, we might give the patient nitroglycerin. See, like it's mentioned in this option that nitroglycerin was given to the patient. So nitroglycerin causes vasodilation, and if vasodilation occurs, it can cause a headache. So this is also expected. After that is increased appetite. If the appetite is increased, it means this is a good sign, whereas we have to identify the serious sign. Chest pain not relieved by rest or nitroglycerin. Yes, if the chest pain is not relieved even after giving nitroglycerin, it means there is some problem here. Usually what happens is when inside the patient, in this coronary artery of ours, here where this clot has formed or the lipid plug has formed, because of giving nitroglycerin, if we give nitroglycerin, it will dilate. If nitroglycerin is given to the patient, then this coronary artery will dilate. If it dilates, more blood will reach, so this means we can understand that the coronary artery is not completely blocked. But if despite giving nitroglycerin, there is no relief in pain, then it means there is a complete blockage here. See how? Because if, let's say, this plug keeps getting bigger here, then oxygen supply decreased from here. Decreased means inside this heart cell, the myocardium cell, what usually happens? In a normally healthy person, here, glucose plus oxygen, these two together form ATP, meaning energy. And because of that, the heart's myocardium gets energy and it contracts. And there is no pain here. But as the plug formed here, less oxygen came. If less oxygen comes, it means oxygen will not bind with glucose. If it doesn't bind, anaerobic metabolism starts. So because of that, lactic acid will be formed, and this lactic acid will come out of the cell. Lactic acid will be formed here too, and lactic acid will be formed here as well. This lactic acid will then irritate the nerves. It will irritate this nerve. And if the nerve is irritated, it means there will be pain here. So the pain in the chest happens for this reason. But as soon as we give nitroglycerin to the patient, this coronary artery will dilate. If it dilates, it means its diameter will widen. If it dilates, it means more blood will flow. If more blood flows, then the cells here will start getting oxygen. Once they start getting oxygen, the anaerobic metabolism happening will switch to aerobic metabolism. This means glucose will combine with oxygen to make ATP. When glucose makes ATP with oxygen, lactic acid isn't formed. So, like when nitroglycerin was given, the coronary artery dilated and more blood flowed. More blood means more oxygen reached the heart cells, so ATP was made. Since ATP was made with oxygen, lactic acid disappeared. Once lactic acid is gone, these nerves aren't irritated, so there's no pain. This means the pain is gone, so we can understand that the coronary artery was only partially blocked. It wasn't completely blocked, but if the pain didn't subside even after giving nitroglycerin, it means you keep giving nitroglycerin, but it might be completely blocked. If it's completely blocked, it means no matter how much nitroglycerin you give, what will happen? It is dilating, but it's completely blocked. Because of the blockage, blood won't flow forward, which means we can understand that now. Instead of nitroglycerin, we'll have to shift to another treatment where we perform PCI, which is percutaneous coronary intervention, in which we perform angioplasty to break this clot, or we place a stent here. So this means if the pain isn't relieved by nitroglycerin here, it means this condition, this situation is dangerous for the patient. So the correct answer here will be chest pain that is not relieved by rest or nitroglycerin. Why is chest pain relieved by rest? Because you have to see that when the coronary artery is blocked, it means the oxygen supply to the myocardium is reduced. But if the demand decreases, we can manage it. There won't be a mismatch. If supply is low, then reduce the demand. That is, have the patient rest. So as the patient rests, it means the heart has to work less. It has to work less, which means if less oxygen was coming from that side, what will they do? That way, there won't be a mismatch. Demand and supply will balance out, and because of that, the pain will be relieved. Suppose the patient has an MI, and you have the patient do even more activity, like running or running on a treadmill, or exercising, then their energy demand will increase. There will be more demand. These cells will have to work harder. The heart will have to pump more blood out. The heart rate will have to increase, and because of that, its demand will rise. For oxygen, so oxygen supply is low from behind, and here the demand is high. Because the heart is working harder, then lactic acid will start to form. When lactic acid forms, these nerves get irritated and that same chest pain starts again. So this means if you had them rest, and with rest, this pain decreased, then we can say that the coronary artery was blocked, but only partially. But if it's not being relieved, it means it's completely blocked. So we'll have to change its treatment. A client presents to the emergency department with severe chest pain radiating to the left arm. The provider suspects an acute myocardial infarction. Which laboratory finding most definitively confirms myocardial necrosis? This means most definitively. So if a patient has an MI, then certain enzymes in the body, in the blood, will increase. But out of those enzymes, which one is it that most definitively tells us it's elevated due to myocardial infarction? So troponin I is the most specific one, because troponin I is found in the heart muscles, myocardium, and it's not found anywhere else. If it's elevated in the blood, then we can say that definitely, there's damage in our heart's myocardium. This means the patient has had an MI. So this will be the correct answer here. CKMB also increases in myocardial infarction, but CKMB is also found in our skeletal muscles, meaning it's found in all the skeletal muscles throughout our body. So we can't say if the damage occurred in those skeletal muscles or if it's an MI, meaning damage in the myocardium. Myoglobin elevation. Myoglobin is also released from the heart's myocardium cells when they're damaged, and it's also released when skeletal muscles are damaged. So this means it's not specific either, because the damage could potentially be in the skeletal muscles somewhere. BNP. This is called brain natriuretic peptide enzyme. It's secreted by the heart, in the heart, and this happens when the stretch in the heart increases, meaning when there's more stretch in the heart, it gets secreted. So this isn't related to heart damage, it's mostly seen in heart failure conditions. So we'll rule this out too. A patient with a history of myocardial infarction is prescribed metoprolol. LOL means it's a beta blocker, and beta blockers always lower the heart rate. During the morning assessment, the nurse notes the following vital signs. Heart rate 52, which means the heart rate is low, so the patient has bradycardia. Blood pressure 100/60, which is a bit on the upper borderline, but the patient has bradycardia. The patient reports mild dizziness but denies chest pain. What is the nurse's priority action? So what will you do for the patient? If the patient is prescribed metoprolol and their heart rate is low, what will you do? Always remember, whenever a patient is on a beta blocker, if the heart rate is below 60, you withhold the beta blocker because it will cause further bradycardia in the patient. You must remember that these questions are asked very often, like if a patient is being given digoxin, you must check the patient's heart rate whenever giving digoxin. If it's below 60, we withhold the digoxin. This question is asked a lot. Then another one is about morphine. When a patient is being given morphine, if their respiratory rate is below 12, we must withhold the morphine. Another one that's asked is, yes, nitroglycerin. With nitroglycerin, if there's hypotension, meaning if the systolic blood pressure is below 90, we withhold that too. So remember, if nitroglycerin is being given to a patient, we must monitor the blood pressure. And if the blood pressure is less than 90 millimeters of mercury, meaning the systolic blood pressure is less than 90 millimeters of mercury, we should withhold it. If we talk about digoxin, we need to check the heart rate. If it's less than 60, we should withhold it. Besides that, morphine. In morphine, we check the respiratory rate. If the respiratory rate is less than 12, we should withhold the morphine. Remember this, in beta blockers, we check the heart rate. If it's less than 60, we'll withhold the medication. Administer the scheduled dose of metoprolol. If we give more metoprolol, it will cause more bradycardia, so we'll mark this as incorrect here. Administer the half dose. We can't do a half dose either. Encourage the patient to ambulate to increase the heart rate, meaning we'll have the patient ambulate, but we shouldn't do that because the patient has a myocardial infarction. If we make them ambulate more, the oxygen demand will increase further, which we don't want in a patient with myocardial infarction. And the last option here didn't show up when I was making my slide, so I'll just tell you what it is. The last option is withhold the medication. Yes, what do we need to do with the medication? We have to withhold it so that more bradycardia doesn't occur. A 72-year-old patient arrives at the emergency department complaining of indigestion, mild nausea, and upper abdominal discomfort for the past 2 hours. The patient denies chest pain, meaning the patient is saying that he didn't have chest pain, he only had abdominal distension, nausea, and indigestion. The patient's vital signs are stable. But which symptom is most likely to delay? Meaning, which symptom is it that will delay the diagnosis of myocardial infarction in the patient? If the patient had an MI, which of these symptoms could cause a delay in the diagnosis of that MI? So chest pain, if the patient has chest pain and tells us right away that they have pain in their chest, we can immediately suspect an MI, so it won't be this one. And pain in the arm is also MI pain, so that won't cause a delay either. There's epigastric discomfort. If there's epigastric discomfort, the patient might think, this is just some gastric issue, like pain from the stomach due to indigestion. So this could delay things for the patient. Next is diaphoresis. Diaphoresis is also commonly seen in heart, myocardial infarction, because whenever the patient has a lack of oxygen, inside the heart, in the heart's myocardium, our sympathetic nervous system gets activated. Because the sympathetic nervous system is activated, the patient sweats a lot or diaphoresis occurs. A client with acute myocardial infarction, MI, has just undergone a percutaneous coronary intervention, PCI, via the femoral artery. That is, a PCI was performed through the femoral artery, meaning a percutaneous coronary intervention was done, which might involve coronary angioplasty being performed. Which nursing action is most important immediately after the procedure? Yes, if we've done an angioplasty through the femoral artery, or a percutaneous coronary intervention, what's the first thing the nurse will do? That is, in the postoperative condition, what's the nurse's first action? Monitor for chest pain relief. Whether or not they got relief from chest pain, there's no need to assess that immediately. Keep the affected leg straight and immobilized. Yes, the affected leg must be kept straight and immobilized so that the clot doesn't get dislodged. But there's something even more important than that. So we'll rule this out. Encourage oral fluid intake. Yes, we'll also increase oral fluid intake because the patient might have been given dye, and to flush out that dye or contrast, we need to increase oral fluids. But this isn't the immediate priority. As soon as the patient comes out of the postoperative condition, assess for bleeding at the insertion site. Yes, when it comes to the insertion site, whether it was inserted through the femoral or through the radial artery, since it's in an artery, it means the pressure is high. Since the pressure is high, there will be a chance of bleeding, and the patient could go into hypotension and shock if there's severe bleeding. So as soon as they arrive, what do we need to check in the patient? We need to check for bleeding. A client with acute myocardial infarction, MI, is prescribed sublingual nitroglycerin for chest pain. Before administering the medication, which action by the nurse is most appropriate? That is, there's a patient with myocardial infarction and nitroglycerin has been prescribed for them. But before starting that, what's the first thing the nurse will do? Assess the client's blood pressure. Yes, we assess the blood pressure because nitroglycerin will dilate blood vessels everywhere in the body, whether it's the brain, the heart, or any other blood vessels. It'll dilate them, which means it'll cause hypotension. There are chances of hypotension, so first we have to check the blood pressure. If there's hypotension, we won't give it. So we must check the blood pressure. So this will be the correct answer here. Ask the client to rate chest pain on a scale of 0 to 10, meaning the patient will tell us about the pain in their chest on a scale, so there's no need to check this before giving nitroglycerin. Instruct the client to sit upright. This is also not that important here. Administer oxygen via nasal cannula. If the patient is given nitroglycerin, then giving oxygen is not such a priority because what it does is we have to see that nitroglycerin always causes hypotension, it causes vasodilation. It will cause vasodilation. So there might be chances of hypotension, so the patient's blood pressure shouldn't be high beforehand. A client with a history of stable angina developed sudden chest pain while resting, meaning when the patient was resting, they had sudden chest pain. The nurse administers 1 sublingual nitroglycerin tablet. This means she has given 1 sublingual nitroglycerin to the patient. After 5 minutes, the client reports persistent chest pain rated 6 by 10. 2 additional doses are given at 5-minute intervals. This means that so far we have given the patient a total of 3 nitroglycerin doses at 5-minute intervals. After the 3rd dose, the client continues to report chest pain. Even after that, the patient has chest pain. What is the nurse's next best action? So what will the nurse do now? So what will happen is that we can only give 3 doses at 5-minute intervals. If the patient doesn't get relief after that, then it means we can understand that now this patient needs another management. Maybe they're not getting relief from nitroglycerin. Maybe the coronary artery is completely blocked. So now if we give them more nitroglycerin, then nitroglycerin will cause a lot of vasodilation, and due to vasodilation, there are chances of severe hypotension in the patient. So we won't give it after 3 doses. Now we will inform the doctor. So the first option is administer a 4th dose. Now we won't give a 4th dose at all. This is wrong here. Reassess pain after another 10 minutes. No, if 3 doses have been given, there's no need to reassess after that. There's no need to wait for 10 minutes for the patient's pain. Activate emergency response system? Yes, we have to inform the doctor. This will be the correct action here. Instruct the client to rest and monitor symptoms. No, if we tell the patient to rest and monitor, then what will happen is that it will delay the next management. So this will also be wrong here. So these were today's questions. See you tomorrow in a new episode. Thank you.